Ground rounds. It's my pleasure to introduce today's speaker, Dr. Sarah Reid. Sarah is an associate professor in the departments of pediatrics and emergency medicine and an emergentologist here at CHIO. She completed her medical degree and her training in pediatrics and a fellowship in pediatric emergency medicine, all at the University of Ottawa here at CHIO. Her academic interest really focuses on the care of children seen outside of pediatric hospitals. She is the editor and Ontario lead for Translating Emergency Knowledge for Kids, or TREC, a national knowledge translation initiative that develops clinical resources for important pediatric emergency topics and has taught emergency medicine broadly across the country in that regard. In 2018, Sarah was elected to the Council of the College of Physicians and Surgeons of Ontario. And in addition to that, she's occupied the role of Vice Chair of the Quality Assurance Committee and is a member of the Policy Review Working Group at CPSO. And it is CPSO that is the focus of her presentation today with the title Beyond the White Paper, the CPSO in 2021. Sarah, look forward to your talk.
Great, thank you so much, Kieran. It's my pleasure to be here this morning. You know, over the last year, we've had to be really responsive and innovative in terms of our response to the pandemic. And we've just seen so much hard work and dedication amongst the physicians at CHIO and in my own department. So it's my pleasure and a privilege for me to be here presenting on behalf of the CPSO and to really thank you for your incredible work over the last 12 months, caring for children and youth and their families. So let's get started. You might be wondering about the title of my talk. I think maybe some people had a little chuckle when they saw it. Hopefully you did. And you know, when we talk to physicians about the college, many people have this vision of this envelope that's going to come someday, that's going to be the harbinger of doom and tell you that you've actually been the subject of a complaint around your care. And this is often what people think about when they think about the CPSO. I'm hoping today that I can share with you some of the things I've learned over the last 2 years and maybe address some misconceptions and talk a little bit about how the college has evolved over the last few years and some of the new programs that are taking place that really actually change how the college does its work. And I think hopefully you'll find this interesting. So before we start, I'm going to get you to do a little warm up with me. So we're going to move over to a different website in a second, but what I'd like you to do is pull out your phone or open a new tab on your computer. And we're going to make a word cloud together. So basically what I'm hoping that you're going to do for me is, I think, you know, some people think about a dreaded white envelope when they hear the word CPSO or the college, but I want to know what you think. Okay, so we're going to move over to a different website and we're going to build a word cloud together. Okay, just so we're okay, so hopefully you can see this. So I need you to open a website, www.menti.com. And on the homepage, you're going to see that there's a space to put in a 7-digit code, which is there at the top of the screen, 8551945. And I want you to answer this question for me. So there's a spot once you put in the code to put in up to 3 words that you think of when you hear CPSO. And so we're going to hope that all the technology works this morning. And as you begin to populate that initial form, we're going to hopefully start seeing some words popping up on the screen. Okay, so we'll just see how these resonate with everybody. So I think we're seeing quite a lot of fairly negative adjectives. And this isn't a surprise, right? I like seeing that I'm seeing some advocacy there too, so that's great. And public protection. Discipline, really a major focus for people as they're answering this and building this word cloud. Scary, but some good stuff. So regulation, professional, patient safety. So it's nice to see a balance. But certainly we know that this is often our perception of the colleges is something that we need to fear. But I'm really glad to see that there are some positives there around what we can provide to patients and what our role really is. Okay, I'll give another couple of seconds, see if we can see any more, and then we'll move back over to the other presentation. I'm gonna ask you to do this again at the end, so you can just keep that website open on your device. Okay, so let's stop there. Okay, great. Thanks for playing along. That's excellent. And I'm not surprised by the answers that we got. I think it reflects what many people think about when they think about the college. So I think that some of you may have a really good sense of the legislative framework that sort of is the base of all of how this works. And certainly when I started working at the college, I think I had some idea that there probably was some legislation that sort of drove this bus. But I think it's probably helpful for us to talk about it a little bit, if you'll indulge me, just because I think it does provide a sort of framework for how this whole system works in terms of being a regulated health profession. So there are two acts within the Ontario legislation, the Regulated Health Professions Act and the Medicine Act. And those two acts together really provide the framework for how this whole thing works. So, the college exists because the law says it must exist because we are a regulated health profession. And the entire framework of how the college functions in terms of its committees, how licenses are delivered, and how we assess whether physicians have met the standard to have a license, how complaints are investigated, how quality assurance is done. Every single role that the college has is regulated under this Regulated Health Professions Act and the Medicine Act. And all of the regulated health professions in Ontario have the same framework. So the pharmacists, the nurses, everybody, we all kind of act the same way, and all of the colleges are set up the exact same way. So it's very much, there's not a lot of room because it's really very heavily legislated. When we think about the college, what's really codified in this legislation is that this whole idea of us being a self-regulated health profession is based on the idea of a social contract. So in exchange for being able to self-regulate, we are expected through this legislation to put the public interest first. And so the protection of the public is central to every single thing that the college does. So it's always with that lens that the work is done, okay? So this whole arrangement is really built on a notion of a social contract, okay? And so that is that it's a privilege for us to self-regulate. It's a privilege for us to decide if someone has met the standard to be a physician in Ontario. It's a privilege for us to help to work with our peers if we feel a standard isn't being met and work through complaints as peers. It's a privilege for us to decide how we improve quality of care. So all of that autonomy really is a privilege. And both of the pieces of legislation that we talked about say, for sure, we can exercise this regulatory autonomy, but we commit to this public interest. And that is why we really need to respect the privilege and really ensure that the public is protected at every step. And when we think about things that are fundamental to the practice of medicine, it's really that, the competence, the integrity, the altruism, and the promotion of the public good. So that really is the overarching idea for how the college is set up and why the work is done the way it is done. When we think about the Canadian self-regulation model, because all of the health professions are self-regulated, it's really based on this ideal of trust that the government and the government and the public trusts that we as professionals will self-regulate in a way that protects the interests of the public. And so then we're granted this privilege of having the autonomy to manage our own affairs. It's interesting when you look at other jurisdictions, it's not always this way, right? There are in the UK, for example, they do have a body that acts like the CPSO. It's called the General Medical Council, but it also has a government body that oversees everything that it does. So quite a lot of government oversight, a report that is made to Parliament every year. Anytime there's a fitness to practice panel, it's reviewed by this government body that is sort of over the General Medical Council. So a lot more oversight than we experience in Ontario. And so I think it just reminds us that it really is a privilege to have this set up the way it is, and that, if we don't respect and protect the public interest, there's potential for other models of regulation. Okay, so I wanted to move on to talk about the way that the college has sort of evolved in the last few years to regulate. And you may have heard of the term right touch regulation. So if you read Dialogue, if you look at the new electronic version of Dialogue, the e-Dialogue, if you read the strategic plan when it comes in your email, if you look at the annual reports, over the last few years, you'll see this term used quite a lot. And it's a way of regulating that's been adopted by many different jurisdictions and many different professions, actually, not just within healthcare. And so it's worth just talking about that a little bit, because it really does inform all of the work that the college is doing right now. We're going to talk about how things have changed a little bit with this lens of right touch regulation. And so basically right touch is based on doing an assessment of the risk. So you do a proper evaluation of what the risk may be. And then the response is proportionate. So you balance the regulatory force with the risk involved. And so the idea is that if you have too little regulation, then you may expose the public to risk. So for example, if there's a very significant clinical concern with a physician and you don't apply an appropriate amount of regulation or regulatory force to that situation, subsequent patients may be exposed to risk. So that's not really acceptable given what I've just talked to you about in terms of this social contract that we've agreed to. If you have too much regulation, then there's a lot of regulatory effort that's applied to a very low risk complaint or a low risk concern that really doesn't provide, risk public safety. And so that is just an overuse of regulatory force. So that's not good either. And so it's really kind of a Goldilocks principle where you want to find something in the middle. So not too much, not too little, but something in the middle that respects the public interest, that protects the public, but isn't overdoing it. So that's kind of the lens of right touch regulation. So it's proportionate, it's outcome focused, and basically the idea is to try and create a system where physicians can flourish, professionalism can flourish, and that you only need to apply the disciplinary tools when it's absolutely necessary. And so this is a shift in the approach to regulation that the college has adopted over the last few years. So whenever people come to a talk from the college, it's a bit the elephant in the room. We started with talking about a white envelope, so we're going to talk a bit about complaints, and we're going to talk about how the application of right touch regulation has actually really changed how complaints are dealt with, and so I think hopefully this will be of interest to you. So first, let's kind of demystify this whole complaints business, because I think everybody's worried about this. So there's 43,000 physicians on the register in Ontario, and there's about 110 million patient encounters every year in Ontario. And in 2019, there were just over 3,000 physicians who had a complaint. So just putting things in perspective, there were with those physicians, those 3,000 physicians or so, there's about 3,700 complaints. So some people get more than one complaint. And when we look at the complaint data, the vast majority of the complaints are dealt with a very light touch. So about 39% of them are investigated and then there's no further action. And about 37% of them are addressed through an early resolution process that we'll talk about in a moment. So that's almost 80% that are dealt with in a very light touch. But for higher risk complaints, things that are more concerning from a public protection perspective, obviously more needs to be done if we're applying right touch regulation. And so of these 3,700 or so complaints from 2019, we talked about the 76% that are dealt with sort of in a light touch manner because they're lower risk complaints. but about 15% of them are resolved through advice or remediation to the physician. Okay, so that might be that the physician needs to take a communication course or a medical records course or a prescribing course, for example. About 8% are resolved with a caution or an undertaking. And an undertaking is a restriction on the physician's practice. For example, they might need a chaperone. They might not be able to prescribe controlled substances, that sort of thing. And then 1% of the complaints are actually sent to discipline. So those are the most high-risk complaints that are sent to discipline. And you'll know about those cases because they are published in the public record, and you'll see those at the back of dialogue, and they're published on the register. So, you know, if you think about all of these patient encounters, you know, fairly, you know, around 3,000 to 4,000 complaints a year in Ontario, and only 1% of those actually go to discipline. So I asked them to pull just PEDS data for us, just because I think it's just interesting for this audience just to know sort of where do we sit. PEDS is a lower risk specialty for sure in terms of complaints. So this is a 4-year set of data, so from 2016 to 2020. And there were 334 complaints. So that's less than 100 a year. So somewhere, let's say about 80 a year, if we even it out over that time period. 259 physicians. So again, some physicians will get more than one complaint. That's not a surprise. So, but in total, 334 complaints. Not surprisingly, in a pediatric set, we're going to see 3/4 of the complaints come from family or friends. So presumably a caregiver, a parent who are making the complaint on behalf of the patient. About 1/3 happen in the hospital and the rest are out in the community. So that's sort of more for this audience. And you know, 64% required no further action, like we talked about. So again, many of the complaints that are lower risk will have a full investigation done, and then no further action is required. So hopefully that sort of demystifies things a little bit. You know, it's not surprising when you look at the complaint data, the reason for the complaint is pretty similar between specialties. So most, you know, sort of 3/4 are related to clinical care. And then there are other concerns around communication, which we hear about all the time, right? And also a failure, like professionalism issues, for example, in pediatrics, like a failure to do mandatory reporting obligation or something like that. So certainly complaints they happen, but if we think that overall complaints per year in Ontario are somewhere in the high 3,000s, let's say even just rounded up to 4,000, and you know, there's 80 to a pediatrician each year, you know, we're talking about 2% of the complaints. So I think as pediatricians, we can feel pretty good about that data. So I wanted to talk to you about, you know, I've sort of alluded to the fact that there is an early resolution kind of process that some complaints can go through. And this is where the right touch regulation really kind of shines through in terms of the complaint process, because there have been a lot of changes that have occurred over the past few years that have really been associated with quite good feedback from both complainants and physicians. And so let's talk about this doctor. This is Dr. Blue. She's the one who had the envelope at the beginning. So she, let's say it's 2019. So we'll go back to sort of pre-right touch regulation time frame. So it's 2018. She gets a letter from the college saying that she's received a complaint from a parent who has felt on multiple occasions very dismissed in her practice when the father has tried to explore concerns about his child's development, let's say. So it's a communication issue. So she gets this letter. In the background, 3 weeks after receiving the complaint, the college would have been able to contact the complainant and start to gather information to start the investigation. And on average, it would have taken 344 days for the complaint to be closed, even if there was no further action required for this lower risk complaint. So a long time for that to hang over the physician and the complainant's head for sure. So let's fast forward now, it's 2021. Same doctor, same complaint, same issue, so a communication issue. And now we have something called alternate dispute resolution, which is one of the early resolution methods that the college uses. And so the complaint comes in. Within 2 days, the complainant is contacted, and the investigation starts, or the assessment starts. The CPSO is able to triage that complaint, deeming that it's a lower risk complaint around communication. And then the college can offer to both the complainant and the physician that this is a suitable type of complaint for alternate dispute resolution, and would they agree to take part, because both parties need to agree. Both parties do agree that they would like to do that. So there's a mediated discussion between the two parties, talking about perspectives, issues, how can we resolve this? And the complaint is subsequently closed 30 days after it's received. Report written, done. So this is a good example of how Right Touch can address a lower risk complaint without that full regulatory force like we were talking about earlier. So just to show that again, so if we compare, 2018 to now, on average, it was about 3 weeks for the complainant to be contacted versus 2 days now. 16% of cases would be resolved with an early resolution kind of process back in 2018, and now it's almost half are resolved with early resolution. And that sort of 314-day decrease in terms of time to have it be closed. So really a significant improvement in terms of how this all happens. So as I mentioned, the ADR process, or the alternate dispute resolution process, really does involve, first of all, it has to be an appropriate complaint, right? A lower risk complaint as deemed by the initial triage. Secondly, both parties need to agree. And then there's that mediated discussion, which, is often, and it needs to then be satisfactory to both parties in terms of what you sort of land on at the end of the day. There's another type of early resolution that can occur as well, where a physician advisor from the patient advisory service at the, a staff person at the physician advisory service at the college can contact a physician on behalf of the patient and discuss what the patient concerns are, try and get some clarity around whatever the issue was. Perhaps it's something around medical records, perhaps it's something around communication. And then that often leads to a quick, very quick apology that can be, fed back to the patient, a quick resolution of whatever the issue was. And then you avoid that complaint having to go on to the investigations department, having to go on to the inquiry, complaint, and reports committee, and subsequently having to have a formal deliberation and formal decision made. So a huge difference in terms of how you can respond to complaints that are of lower risk that really don't need that full regulatory force applied. And so the result of this is that there's been overall a real improvement in open files. So this is a bar chart that just sort of shows this for you. On the y-axis, we have the number of open cases, and on the x-axis, we have first quarter from 2019 through the fourth quarter, and then the first 2 quarters of 2020. And these are open files. So the dark turquoise is complaints that actually had to have an investigation. So they were not low risk. The light turquoise is those that were able to go through an early resolution process, like we've talked about. And then the middle little bar that you see a little stripe on all of the bars, that medium turquoise color, is complaints that were deemed to be frivolous and vexatious. So I'll tell you about those in a sec. But what I just wanted, this is just sort of a visual for you, is that in the past number of years, the number of complaints per year has been increasing. Okay, so that's just how it is. And you can imagine that if the full amount of regulatory force needed to be applied to every single one of those 4,000 complaints or so a year, the backlog, as more and more complaints started to come in, and it was taking, upwards of a year to resolve each complaint, you can just imagine that it just, the number of open files just continued to increase. And so there was this real backlog of investigations and open complaints that really needed a new approach to dealing with. And so this application of right touch regulation in terms of dealing with those complaints that are deemed to be low risk and of no risk to the public has allowed for the complaints to be resolved more quickly, and thus allowing the resources of the college that deal with complaints to spend their time on the complaints that really need attention and need the full investigation, and then allowed overall, quarter over quarter, a decrease in open files. So this has allowed for a lot more efficiency in the system, decreasing the time for reports to be written by like 90%, and really an improvement in the experience for both the complainant and the physician, because one of the major complaints was that all of these things took so long that it was just really punitive in terms of the amount of time that a complaint would hang over a physician's head, and for the complainant as well. I think it's interesting if we think about the work that our patient experience team does at CHIO, they would, I think, if Jill or Brianna were on this call, they would echo that getting in touch with the complainant very soon after you receive the complaint is fundamental to helping to resolve the issue for the family. It's, if we're out at a restaurant and we make a complaint, or we're at a store and we make a complaint, if it takes a long time for people to get back to you, it escalates things a little bit. So I think that, it just makes sense to get in touch with people early, to show that you really want to hear what they have to say, that you're concerned about it, that you're appropriately acting on their concern, and that helps the whole process work well. So we're doing early resolution and ADR all the time in patient experience when we receive a patient complaint, which I'm involved in from the emergency department perspective. And so, this really resonates with me in terms of, how to talk to people when they're upset and concerned about things that have happened. Okay, so we're going to move on from complaints to talk about the new quality improvement program, okay, which you're going to hear more about, but I just wanted to give you a taste of what's sort of happening in the quality assurance, quality improvement kind of space. So I can't see the chat, so I'm going to ask Michelle Ward, if she's on the call, to check the chat for me here. So if you guys want to just open up your chat, and I'm wondering if anyone in the audience has had a random peer assessment from the college. So that involves a peer assessor coming to your practice and talking to you about your practice, and then doing some chart reviews and giving you some feedback on, opportunities for improvement. Has anyone had that happen? I don't know if Michelle, if you want to pipe in, if we see anybody saying yes, they've had them, or conversely, has anyone been a peer assessor? I don't hear anybody.
Sarah, there are at least 7 or 10 that have said yes, and a few that are also peer assessors.
Okay, thanks very much. Okay, great. So for those of you who've been through it, this was the random peer assessment program. Has been really the basis of the quality assurance program at the college. And of course, quality assurance and quality improvement are both legislated roles of the college. So the quality assurance program really involves a random peer assessment where physicians in Ontario will randomly get a letter from the college saying that they've been selected for peer assessment. And again, as I mentioned, the assessor will come into your practice, assess, take a look at how your practice is set up, your EMR, all of these things, and then do a chart review actually to go through and sort of assess your record keeping, for example, your prescribing, your documentation, all of those things, and your care. And so if with right touch regulation, there's going to be a shift, still doing quality assurance, but also a move to a new quality improvement program. So we'll just take a moment to sort of talk about what's the difference. So quality assurance, this is sort of a visual for you on the left. You can see that vertical line, which is like a threshold below which we take action. So if a physician in our case doesn't meet a particular threshold in terms of their medical record keeping, then the quality assurance committee would give them directed feedback, or sort of a graded intervention in terms of trying to get them to meet the standard. So you can see the red area under the curve there on the left that's where action's taken. It's only in a small number of individuals who are not meeting that minimal threshold, and thus it's really going to only affect or improve care for a small number of patients. So shift to the right, and this is kind of the way of thinking about quality improvement, where you take an approach that's broader, that applies to everyone, that is moving the curve, hopefully, over to the right towards better quality. And so the impact from a patient and population perspective is much higher. And so that's sort of a way of kind of thinking about the two systems. Both are important, but really with this right touch regulation lens, the college is moving towards this novel new quality improvement program that was just sort of rolled out in March of 2020, and that we'll be hearing about more. So I'm going to talk to you a little bit more about that. When we're thinking about quality assurance versus quality improvement, quality assurance, we're meeting this minimum standard, whereas with quality improvement, we can kind of break the ceiling and move everyone over to the right. So I think I'm preaching to the converted. CHIO is an institution that has really adopted a quality improvement strategic direction, and continuous improvement is part of sort of what we live and breathe. And so I don't think this is coming as a surprise to anyone in this audience, but suffice it to say, for others, perhaps they haven't been involved in a lot of QI, and so they may not be as comfortable with this shift. But I think you can imagine that if we're only doing random peer assessments, that in-person, random kind of way of checking to see how doctors are doing, it really doesn't have as much impact. And we're not touching physicians as often as we should, based on probably what the public would expect from a quality improvement perspective. And so the new QI program, as I mentioned, was launched back in 2020 in March, which obviously is not an amazing time to launch any kind of program, but it actually has been quite successful in terms of the rollout. It was initially piloted with back in 2019 with about just over 200 family physicians who volunteered to take part. And there are two types of programs. So the one on the left of this little graphic here is the QI program for individuals and groups. So that's docs that are in solo practice or in group practice. And then there's another part of the program that's called the QI partnership program. And that's going to be more applicable to us who are hospital-based physicians. So I'll talk first about the QI program for individuals and groups. And so this is the one that was rolled out and is actually going, and the partnership program is sort of the second phase. So for doctors who are out in the community or in solo practice or in groups, basically it's a program that it probably takes about 12 hours to do the whole thing. It's going to be every 5 years you're required to do it. You're eligible for CPD credits when you do it. And once you've completed it, you're exempt for 5 years, and then you'll be back into the system. So the idea is that 20% of Ontario doctors would be involved in the program at any one time. So the program basically is first of all, it's all electronic. So there's a new platform that's being built on the CPSO website that it's called the Learning Management System, that has all the tools, all the templates, all the everything you need to do is online. So it's very easy. The initial thing that you do is you do something called a practice profile. So that's just spending a bit of time thinking about your practice and using some college data to assess risk in your practice, assess opportunity to improve in your practice. The next step is to do a self-guided chart review, again, using some tools developed by the college that reflect the policies on medical record keeping and that sort of thing. So, we can all, I'm sure all of us could improve our medical record keeping. And so this is just a way of really assessing, how am I doing from that perspective? And then the program uses data that's available on standard of care and perhaps comparing how we're doing to our peers and to standards that are set. So a family physician, for example, it might be around, how well am I checking the A1C of my diabetic patients? How am I doing with my cancer screening? How am I doing with my immunizations? There are standards that we're supposed to meet. And so this program kind of uses data to inform the doctor about where maybe I'm meeting the standard, maybe where I could be improving. And then the physician themselves come up with a QI program or a plan that's reviewed at the college, and then they're expected to continue. So they're expected to complete the program. So it's based on self-reflection. It's based on the use of data. It's trusting physicians to do this, to start to do and to repeatedly and recurrently and adopt a QI kind of lens to their practice. So it's quite novel, but it's trusting in the professionalism of doctors and allowing them to sort of adopt that sort of lifelong learning that we all talk about, but it's a way that the college is going to now try and touch physicians in Ontario a lot more frequently. And for those physicians who are having a hard time, there's coaching available from the college. And for those physicians who don't engage in the program or who really aren't able to come up with a reasonable QI plan, then peer assessment will still exist for them. Okay, so that's kind of a bit of an overview of this new QI program. For us who work in a hospital, it's a little bit different. And the reason for that is because many institutions already have a very robust QI program. And so it would be redundant for us to have to do our own thing on our own. And then the hospital is also running, institutionally, we have all these strategies for continuous improvement and QI. So the idea for the hospital-based physicians is that we'll do the first two steps. So that practice profile, just assessing doing a little sort of thinking about what's my practice like, who are the patients I see, is there any risk that, it can be identified in terms of how I practice, for example. And then secondly, doing a self-guided chart review. And those two first steps seems that they take about 2 to 3 hours. Subsequently, as an institution, we'll decide on a QI program that will be accepted by the CPSO, and we'll move forward with that. And if we participate, then we're exempt for 5 years, we're eligible for CPD credits, and that's how it's going to work. So the idea for the hospital-based physician is that we're going to limit the redundancy, and so that it'll really hopefully be integrated into what we're already doing. And I feel like when I read the program, I think, I can think of many things that we've done over the years as QI initiatives at the hospital level that, hopefully will inform, a new program that we can come up with together that everybody wants to participate in. So I know that Lindy may want to say a little bit more about this at the end, but I know that the CPSO has been in touch. The hospital is aware of this program and that we're going to be moving forward with it. And the physician lead for QI is going to be coming to speak at the MAC in March. So more to come, but just be aware that there is a new QI program that's coming down the pike, and hopefully it'll be fairly streamlined and it'll be really useful for all of us. So I'm just going to shift now to talk about policies. I am on the policy review working group at the college, and I just wanted to talk to you a little bit about the policies and policy consultation, just to see if anybody wants to take part. So maybe to start, I'll ask, has anyone taken part in a policy consultation from the college? So this is when the college will email out, or on social media, you'll see that there's an invitation to give comments on a policy that's up for review. And we do get lots of comments back from stakeholders like like CMPA, OMA, individual physicians, PARO, the medical students, the Royal College. There's a lot of stakeholders that often provide feedback, and also individual physicians and lots of members of the public. So I'm just wondering if anyone in the audience has ever had to or ever participated in one of those policy consultations. Maybe Michelle, you can tell me if anyone says yes.
Just one so far says that they've given some online comments.
Okay, yeah, it's online, so that's good. Okay, well, maybe at the end of this, you'll think, maybe I'll do that. Okay, so I'll tell you about this a little bit more. So you know that the CPSO's role one of the key duties is to provide some guidance to physicians around professionalism and issues related to the practice of medicine. So this is what's commonly known as the policies. There's also a practice guide that I confess, I've looked at it since, but I hadn't looked at the practice guide since I got my license for independent practice back in the day. So, and maybe you feel the same way, you haven't looked at it recently, but there's a practice guide, and then there's 38 policies that tell us what we need to do and when we need to do it. So they're all available online. I chose boundary violations, not because I'm concerned about boundary violations in this audience, but it is a source of a number of complaints. So it's a good one to know about for sure. It's a good one for the learners to know about for sure. And so within the policies, just a couple of words with the right touch regulation lens, they've all been decreased in length and edited for readability and clarity. So all of them have decreased about 40% in length. They used to be quite lengthy and you'd be reading through and it wasn't really tight. And now all of the policies have been rewritten in like the same format, very tight, using the words must and the word advised. So when the phrase says, a physician must, then it's pretty clear. There's not really room to debate. But within the policies, you'll sometimes see a physician is advised to, and when the word advised is used, it sort of allows us to use reasonable discretion. So again, respecting the physician's professionalism when you're applying that to your practice, okay? So when policies, they get reviewed regularly, as you would expect, and there's usually 2 time points when consultations may be invited. So many of them, before they even go out, before they even get updated at all, will go out for a consultation, sort of get a bit of the lay of the land, a bit of an environmental scan. What are people thinking about this policy? And then all of them will get, there will be a request for consultation before they're finalized. So when there's a draft ready, that will be sent out for consultation to get more comments. So many of them have 2 consultations. All of them will at least have 1. So that consultation period usually is about 60 days. And again, you're invited on social media, you're invited through your email. It's an opportunity to provide some feedback because, it's from the practicing physicians that you hear, is this a reasonable expectation? What's working, what's not? Is there a gap? Is there something around patient care that we've missed? And so it's really helpful to have the sort of boots on the ground giving that kind of feedback. It's really, really critical, actually. So I would invite you to keep an eye out. Last year in the fall, back in fall of 2019, the continuity of care policy was up for renewal. That obviously is a huge issue in terms of quality of care. And so that consultation actually was extended to 6 months because there was so much engagement. The college really needed to focus on what are the things around continuity of care that physicians are in control of, right? What, not system issues, but actually what do we have, what are we responsible for within this complex system? And so it ended up being, after that 6-month consultation, which was really helpful, it ended up being that the continuity of care policy actually was split into 4 separate policies. So there's one on availability and coverage. There's one on managing tests. There's one on transitions of care, and then walk-in clinics, which, that may not have been as big of an issue when the policy was initially conceived of, right? But lots of people receiving their primary care in walk-in clinics. So, a big issue that needs to be addressed in terms of continuity. So I think it landed in a good spot, but with lots and lots of consultation. So definitely the college is open to that engagement with the public, with the profession, and with stakeholders, and trying to sort of hit that sort of sweet spot where it's not too much regulation, not too little, and we're protecting the public. And so the other thing I'll just mention about continuity of care, there is a new companion document that just got published in 2020 in December that is for patients and for caregivers. And it basically sort of invites them to be partners in continuity of care and provides them with really good suggestions about how to keep track of their medical issues, their medications, for example, and what expectations they should have around continuity of care as well. So empowering the caregiver. And that was written with help from the Citizen Advisory Group, which is a provincial sort of patient engagement group that the CPSO is in charge of this year. So so lots of things happening in terms of policy development, and we probably will start making more companion documents for patients themselves to sort of really engage them in the process in terms of what they should expect from their medical care and what responsibilities they have as well. All of the policies have their own little partner document called the Advice to the Profession document, which is basically set up in a question and answer format, which is sort of FAQs around different policies, goes into a little bit more about the application in practice. If there's some nuances, that's explored in this kind of document. So lots of footnotes in terms of whether it relates to legislation or previous cases and that sort of thing. So just be aware that there are 2 documents for each policy. So lastly, I'll just talk about the telemedicine policy a little bit, because I think that, if we were going to say that the pandemic has changed the landscape of virtual care, that would be an understatement. This is a picture of Dr. Reid Jane from the emergency department. She's doing virtual care. That's actually her husband and her son in the photograph. We just use this to advertise the virtual emerge. So I chose this photograph because, the telemedicine policy was up for renewal this year. And there was a very active consultation process that happened in the fall, because obviously, we were doing some virtual care before, but now we're really doing it. And so there's many questions that have come up in terms of how to do this safely, how to really promote and optimize the quality of care that's being offered, and what are the pitfalls around virtual care as well. So that consultation period ended in November, and so coming this year there will be a new telemedicine policy that will be coming out. That we also hosted a focus group, focus groups that were virtual, of course, in the fall with patients and physicians around virtual care. And there was a lot of rich discussion there. Actually, Sandy C. from Emerge participated as well. She was our lead for the virtual Emerge. So, lots of questions, many things from physicians around how to use, what platform to use. Is it okay to use unencrypted platforms like FaceTime and Zoom? So not as much of an issue for us given the platforms that we're using. But interestingly, from patients, many prefer virtual care, probably from a convenience perspective alone, but also really have a lot of questions about when they should be seen in person. So when is it not appropriate? And so that's a real, there's a lot of questions to answer and to work through in terms of what this new policy is going to look like, given all the experience that we've had over the course of the pandemic. So that one's done, but that policy will be coming out later this year. So the 4 policies that are currently open for consultation, in case you are interested, the MAID is up for revision, quality end of life care, complementary and alternative medicine, and lastly, the professional obligations and human rights. So there's 4 big ones that are out for consultation right now. So if you're interested, you can just go on the website and look on the consultation page, and they're there, and it's easy. You can review what's there and then just type in your comments. So pretty easy if that's something that you want to get involved in. Okay, so I think we're nearing the end, and I just wanted to finish with reminding you that the vision from the college is trusted doctors providing great care. And, I think as healthcare providers, we have a sense of what great care looks like. We know it when we see it, for sure. We know it when we feel it, or when we're involved in it. But we're going to finish off, we're going to do another word cloud. So I want you not to think of this from a doctor lens, this question, or from a healthcare provider lens. What I'd like you to do is think about, everybody in this audience has been a patient, I'm sure, at least once. And if you haven't really been a patient or you haven't really had that much contact as a patient, I think you've been a caregiver or you've been at the bedside of a loved one. And you know what that feels like, and you know what it feels like when the care isn't great, but you also know what it feels like when it is great. So I'm going to stop the share here, and we're going to move over to Menti, and you're going to answer my next question. Okay, so it should be the same code, and you should see my next question now. And so I want you with a patient or a caregiver.
Sarah.
Oh, you don't see it, shucks. Okay, hold on a second. Let me try that again. You see it now? Okay, so remember, I want you to answer this question as a patient or as a caregiver. Yeah, I'm not surprised that compassionate is our number one there. But, you know, understanding, informed, attentive, thorough, competent, all these things, right? That we know it when we feel it, and we know it when we see it, and we know it when we experience it. So I know that these are the words that guide our care every day. And I, again, on behalf of the college, I thank you so much for your incredible dedication, especially over the last year. And I think I'll stop it there. Thank you so much for participating.
Great. Thank you very much, Sarah. That was really an excellent presentation, and thank you also for all the work you do at CPSO and that you bring back here to us, because I think it's really tremendous, supporting all of our group in an incredible way. I just have one question around it. It's great to see with the Right Touch change and the significant reduction in the duration of time it takes for resolution of a complaint. Does that automatically assume that the complaint was justified? And is there a way to close the loop on that? And I guess an extension of that is, if it is felt that the complaint wasn't justified, is that expunged from the physician's record?
Yeah, that's a great question. And you know what, I realized I didn't talk to you about the frivolous and vexatious bar on the little stripes on those bars that I showed you on the bar chart showing the open files. So there is a group of complaints that are deemed to be frivolous and vexatious. Okay, and so a good example of that one, those types of complaints are a couple of years ago, and you probably saw this in the news. There's a trauma surgeon from St. Mike's in Toronto who is a gun control advocate, and she was targeted with over 70 complaints from a pro-gun lobby. And so those were deemed to be frivolous and vexatious, and they were dismissed sort of, you know, after a very cursory review. Okay, so that there is room in the legislation to do that with that type of complaint. In terms of your question around others, so, you know, the complaint needs to go through a full investigation, remembering that the lower risk complaints that are deemed to be lower risk are going to do an early resolution process, but the ones that go through the full investigation, I don't believe that there is a way for that to be expunged, but like expunged from the record. It's still, it's only the discipline cases that are part of the public record or published, if that makes sense. So there's a medium ground where, and I certainly can take this back and clarify that for you if you like, but my understanding is that once the full investigation, it's in your record, but it's not fully published. Is that fair? And that the resolution of it would be part of your record. So if it's deemed to be, completely resolved with no further action, then that kind of says it all.
Yeah, just
fair?
to be clear, I'm not concerned about it on a personal.
No, I know that. No, I think it's a very good question, because I think that's what people do worry about. That what happens if you have a complaint it's not justified, and we feel vulnerable. That's totally fair. Yeah, absolutely.
Well, it really speaks to the issue of if there's a subsequent complaint, then there's a prior complaint inform the subsequent complaint. And
well, it is part of the physician's record for sure, but it's extremely well documented. And so if that was the conclusion from the committee, and remember, this is a committee that's made up of your peers, right? Mm-hmm. If it's deemed, the conclusion is going to take that into account. And I know even cases that come to the Quality Assurance Committee, previous interaction with the college doesn't necessarily, like if it's being dealt with and closed off and the physician has done what they need to do, it doesn't necessarily inform, or be additive in that way. Yeah.
Okay, great, thank you. Other questions? If you can raise your blue hand, or if not, I don't see any other questions in the chat. Stuart? Can't hear you. Sorry, Stuart, we can't hear. Maybe we'll move on. If there's somebody else we can connect. Michelle.
Sorry, I didn't intend to raise my hand. Is it up?
Yeah.
I don't know. Nope. I just wanted to say thank you. Much less of a black box for the white envelope now.
Thanks. And thanks for your help, Bud, taking our chat. Yeah.
So I don't know if there's Mateen Akhtar.
Hi, my name is Mateen. I'm a third-year med student. So, great talk, Dr. Reid. I just had a very quick question in terms of like how the CPSO deals with complaints. Is there any information from the CPSO side on individuals that are filing the complaints? Is there some sort of like database for that, or is that not taken into account?
No, there's no database for that. No. Like in terms of publishing or something that's a matter of the public record?
No. Just like, for example, if one individual has made like multiple complaints, like, is that taken into account?
Yeah, that's a good question. I think it probably is taken into account. And there is, of course, this is all fully documented. So in the background, yes, I think that would be taken into account. And that probably goes to this, the frivolous, vexatious kind of type of comment, type of complaint process as well. There, that is taken into account and tracked. Yeah.
All right. Thanks.
Other questions? I don't see any more hands, so I'd just like to, on behalf of the department, thank Sarah for a tremendous presentation and generating interesting conversation. We'll draw it to a close. Thank you.
Thank you very much.